pointed out, that seems to be one of the most exciting newer breakthroughs in our whole vascular armamentarium. And at the same time, all of us have done and were involved, and I had the luxury of doing a case of superior mesenteric arterial ischemia, whereby, like any other arterial system, if you have compromise in that system, patient was struggling with even having a simple meal and digesting it, and had excruciating pain after each meal, to the point she lost several pounds of weight. And also we had the opportunity to see great leaders like Dr. Mark Woolley come in and participate in our conference, and he also received an honorary award that is presented by our conference, honoring him for all his accomplishments and his contributions in the field of carotid disease. And furthermore, where do you see the direction of new cardiovascular horizons further emerging, coming out year after year? Where do you see it growing, both in the scope of the conference in terms of its width and doing it in a transatlantic or in other areas, as well as regionally within New Orleans and in the national arena?
Sure. Well, it's already one of the biggest conferences in the world. And this year we had attendees and faculty, frankly, from every inhabited continent in the world. That's pretty big. But we are doing things to reach out to other areas. We each year now have added New Cardiovascular Horizons China, and we have a meeting in China. We're going this year to Costa Rica. We're doing regional meetings. We'll do one later this year here in Lafayette. We have several of these around the United States that are planned. But this whole field is simply exploding as we see more and more data showing carotid stenting not just to be as good, but perhaps better than carotid endarterectomy, with less risk and less pain and less time in the hospital. This is certainly exciting data as we watch critical limb ischemia evolve. We were mentioning earlier, many of these patients are too sick to have surgery, but on top of that, many can't have surgery even if they weren't sick. The vessels distally towards the foot are too small in those cases, so the surgeon can't place a conduit or a bypass around them because the vessels are severely diseased. There is no such thing as a vessel too small to have angioplasty. It can be stretched out. So we can treat many patients who simply have no other option. We've not even discussed the venous side of the problem, but it's a huge problem. And one of the things next year I think we will address a little bit more in detail is the venous disease segment. This year we had more live cases than any other conference in the world. We had more stuff about critical limb ischemia and a whole day of nothing but critical limb ischemia. I also suspect we're going to grow the venous symposium in the future. Venous disease leads to big problems. It can lead to ulcers. It's one of the causes, one of the biggest causes of sudden death when people throw blood clots to the lungs. And so we know we can do a better job in how this disease is treated as well. And we're giving more and more attention to that side. I call it the forgotten side of the circulation. But I suspect in the future we're going to have to increase the number of days of the conference because there's an awful lot of material to cover. And we want to make sure that every single person who attends this conference leaves more capable of treating their patients.
Exactly right. Venous disease certainly remains to be a forgotten side because it becomes kind of a no man's zone, and there are many physicians that are involved in it. And once you have pulmonary embolism, it just is always historically surgical embolectomy or opening the chest and plucking the clot out was an option. If the patients are so critically ill, there is no time to really go out and put the patient under general anesthesia and do a thoracotomy or cut down their chest and pluck the clot. Before that time, the patient will really collapse and move on. And so the emergence of catheter-based techniques for the first time at the conference, all of us have done anecdotally catheter-based extraction or using clot-lysing or clot-busting medicines. The first time we saw a concerted effort by, albeit in a small scale, concerted effort to lyse that clot or to break down that clot and enhance the blood flow to the pulmonary circulation, thereby changing the course of this patient who's otherwise on a very quick path to death. So that's a great, these are several very important lessons that I've taken And I've heard great lectures about treatment of abdominal aortic aneurysms as well, although we haven't yet done a live case yet. And I really foresee, with the emergence of this whole catheter-based technique for treatment of abdominal aortic aneurysms, likely I foresee us doing a live case next year with a percutaneous technique, which is also very exciting to me. And furthermore, I want to also remind our audience it's a live call-in show. We are continuing our discussion about cardiovascular horizons as well as critical ischemia or different aspects of the emerging therapy for peripheral arterial disease. We'll go ahead and take a small break and come back and finish our discussion about horizons and go on to discussion of emerging therapies and insight of the specialists that have graced this studio right now. We'll take a small break.
I never thought it would happen to me.
I never thought it would happen to me. I didn't know women my age were at risk for heart disease.
Heart attacks are by far the most common cause of death in the United States of America. Many occur with no warning symptoms at all. Cardiovascular Institute of the South is the leader in treating cardiovascular and peripheral vascular disease. If you think you may be at risk of having a heart attack, come see us at any one of our 11 locations. Even the very best heart care is of value only if you have access to it. So here's our pledge. If you have chest pains or symptoms of a heart attack, you'll be seen at any hour, day or night. If you don't have symptoms, but you or your doctor have concerns about your heart, you'll be seen within 48 hours. And even a routine heart check will normally be scheduled within a week. CIS is one of the largest, most advanced facilities in the South with an international reputation for treating heart disease. Call us to schedule your appointment.
Welcome back to our monthly live call-in show from the heart with Cardiovascular Institute of South at Appaloosas General Hospital. I'm Dr. Verena, and I have with me Dr. Craig Walker and Dr. Nick Cavros, who are my partners and founding members of the New Cardiovascular Horizons. We have been talking about the whole goal of education of New Cardiovascular Horizons, how it has evolved as a conference over a period, how it has evolved to encompass treatment of critical limb ischemia, carotid disease, and the multidisciplinary involvement of primary care physicians, podiatrists, nurses, nurse practitioners, and cath lab technicians. I want us to go ahead and see a few pictures that we took from the conference just to show the attendance and the whole activity of the conference. And here we have Dr. Cavros sitting on I'm sorry I don't have a live run here, but Dr. Cavros sitting moderating a session here, it looks like, and move on, just show the other pictures. And this is a live case, it looks like, from SimSport here with all the cath lab crew doing a live case there. And at the bottom of it, here you can see the angiograms, and I'm not sure if the audience can appreciate that too well. The physician members sitting at the podium and with Dr. Cavros in the small box there, moderating the session there. And here we see Dr. Walker chairing a session, what looks like involving carotid artery disease, sitting there and moderating that, and the audience. And this is the main auditorium that all the cases were done and the live discussions went on. And again here, this looks like Dr. Walker again from HOMA doing a live case and talking to the audience. This is a very interesting format, interactive, and that seems to be the most exciting time of the whole conference, of everybody going back and forth, bantering and really analyzing. Since we are on live, really, it's all bets are off. I mean, you're on for real, and any potential pitfalls or limitations or problems will be exposed to all the audience, basically. And go on to the next slide, please. And that's the whole auditorium, which is a very lively auditorium with great graphics by our team from Belgium as well. And here, a hall could fit upwards of 1,000 people here for the discussion there. Next slide. And here it looks like my case, and Dr. Woolley is commenting on a superior mesenteric artery. Next case, please. Next slide. And that's me on the podium. It looks like a whole lot of very seasoned experts sitting on and moderating the session. And here I see Dr. Walker and Dr. Woolley, and I can't make out the other guys, but certainly a very lively, world-renowned crew. I've seen Dr. Woolley, I've seen Dr. Julio Palmas, and I've seen Dr. John Simpson. All these are, of course, all of you. Certainly, it's a very exciting time for all of us to get out there and enrich our own education, as well as be able to share a little bit of our information with all the audience. With that insight, and I want us to just move on and talk about some of the new breakthroughs that what, in your opinion, are the new breakthroughs that came on in the field of peripheral vascular disease, starting from the iliac arterial disease, and we are talking, all of us are heavily invested and passionate about this whole peripheral arena, but in your opinion, in the past decade, where has the field moved, and what are the most exciting changes?
Sure. When we first started doing peripheral arterial work, we were really one of just a handful of sites in the whole world doing peripheral arterial intervention. Early on, the biggest problem that we faced was crossing total blockages. It was a huge problem, and you never knew if you would get across. Well, now we have a series of wires and crossing devices that make crossing total blockages commonplace. In fact, it is extraordinarily uncommon to not be able to cross a blockage. Then came about the issue of how do we keep the area open? Once we've crossed it and treated it, how do we open and what makes it stay open? Well, originally all we had was a balloon. One of the men that you saw at the meeting was Dr. Fogarty. He made the first balloon used in medicine, the Fogarty catheter. We had a whole host of luminaries. The man who made the first stent, the man who made the first atherectomy device, the man who made the first power injection device. The world's who's who was at this meeting. So the next step is keeping a vessel open. Well, many times with just a balloon, there's too much elastic recoil, or there are tears inside the vessel that we call dissections that stop it from staying open. So one of the big advances were the stents. Stents hold the vessel open and they stop the elastic recoil and they stop problems. However, we had to make stents that could bend and flex and it could not be compressed. So those have been developed. There have been huge changes in stents over the years. We have made stents which serve as springs and cannot be compressed. And we have stents which are now covered with medicines. We have stents which are covered with membranes to stop the ingrowth of tissue. And we now have better designed stents that are yet stronger and more flexible. We have a whole host of atherectomy tools. That means tools that actually remove the blockage rather than simply stretch it open. One of the areas of greatest excitement right now worldwide is drug delivery, predominantly being used with either stents or drug-eluting balloons, which we don't have yet in the United States, but which I suspect will be, at least in clinical trials, in very near order. So certainly the field has come along tremendously. We went from a field where we never knew actually if we could even always cross, to a field now where you can not only cross, but have fantastic, durable, long-term results. And it's really been quite exciting. Nick mentioned one of the other great areas, this whole concept of renal denervation, which you can do through a catheter. Imagine the promise if you didn't require medicines all of your life for high blood pressure. Medicines are expensive, they have side effects. So if indeed we had a means by which to alleviate hypertension, which is a monstrous healthcare problem across the United States and indeed across the world, this is really a big deal. We touched on percutaneous treatment of aortic valves and mitral valves at the clinic. This is a big problem, again, for patients, and allows new treatment paradigms. So I think that this field is simply exploding, and it's very exciting to see where we're going at this point in time.
Absolutely, that's a great summation of clearly a very extensive arena. And Nick, from the time that you finished training and being involved in training fellows and all that, how did you see the emergence of, how has it been that maybe let's say 20% of the whole cardiovascular specialists or less of